Good morning, everyone. Today we will discuss one of the most important concepts in clinical neurology. So, that is localization of stroke, specifically differentiating cortical stroke from internal capsule or lacunar stroke. As Harrison emphasizes, neurological diagnosis begins with anatomical localization. So, before reviewing imaging, a careful history and neurological examination, so they often predict the lesion's location, vascular territory, underlying mechanism, and prognosis. So, by the end of this discussion, you should be able to distinguish cortical from subcortical stroke confidently at the bedside. So, why is localization important? The first question when evaluating an acute stroke patient is where is the lesion? Okay, where is the lesion? The second question is which blood vessel is involved? What is the second question? Which blood vessel is involved? Third question is what is the underlying mechanism? Okay, so clinical localization answers all these three. So, a patient with aphasia and right hemiplegia. Patient is having aphasia and right hemiplegia. So this immediately suggests a dominant MCA cortical infarct. Aphasia and right hemiplegia immediately suggest a dominant MCA cortical infarct. A patient with dense pure motor hemiplegia but normal language, vision and cognition strongly suggest a lacunar infarct involving the posterior limb of the internal capsule. A dense pure motor hemiplegia is there, but the language is normal, vision and cognition, everything is normal. So this suggests a lacunar infarct involving the posterior limb of the internal capsule. So thus localization guides emergency treatment, vascular imaging, cardiac evaluation, secondary prevention and prognosis. Cortical stroke. So cortical stroke involves the cerebral cortex and most commonly caused by large vessel occlusion including the middle cerebral artery, anterior cerebral artery or posterior cerebral artery territories. Okay, so here in this diagram you can see the orange color middle cerebral artery, green anterior cerebral artery and the blue color is posterior cerebral artery territories. So the hallmark is contralateral weakness. So this will be accompanied by cortical dysfunction. Contralateral weakness will be there. Along with that there will be cortical dysfunction. So what are the important cortical signs? So the important cortical signs include aphasia. The important cortical signs include aphasia, hemispatial neglect, homonymous visual field defects, cortical sensory loss, graphesthesia and stereognosis, apraxia, agnosia, early post-stroke seizures and conjugate gauge deviation toward the side of the lesion. So what are the important cortical signs? The important cortical signs include aphasia in dominant hemisphere. Okay, so hemispatial neglect, this will be in non-dominant hemisphere. Homonymous visual field defect, cortical sensory loss, that is graphesthesia and stereognosis, apraxia, agnosia, early post-stroke seizures and conjugate gauge deviation towards the side of the lesion. So then Broca's aphasia. So this Broca's aphasia causes non-fluent speech. Broca's aphasia, there will be a non-fluent speech. Wernicke's aphasia causes fluent but meaningless speech. Wernicke's aphasia, it is fluent but it is a meaningless, no meaning to the speech. Global aphasia occurs with extensive MCA infarction. Okay, Global aphasia occurs with extensive MCA infarction. Okay. Neglect usually results from right parietal lobe lesions. So if there is a lesion in the right parietal lobe, so neglect usually occurs. Okay. Visual field defects are typically contralateral homonymous hemianopia. So what will be the visual field defect in cortical stroke? So it will be contralateral homonymous hemianopia. Seizures occur in approximately 5 to 10% of acute cortical ischemic strokes and are much less common in lacunar infarction. In lacunar infarction, seizures are less common, but in 5 to 10% of acute cortical ischemic strokes, seizures occur. Then coming to the vascular territories. So, middle cerebral artery, face and arm weakness will be greater than the leg weakness. So when we come to the middle cerebral artery, what will happen is the contralateral face and arm weakness will be greater than the leg weakness. There will be aphasia, dominant hemisphere involvement, neglect in case of non-dominant hemisphere, homonymous hemianopia, and gaze preference to the side of the lesion. So if it is an anterior cerebral artery, if it is involved, there will be a contralateral leg weakness. It is greater than the arm weakness. Anterior cerebral artery means leg weakness greater than arm weakness. Urinary incontinence will be there, ebulia, frontal release signs and behavioral changes will be there in anterior cerebral artery. If it is posterior cerebral artery, again you have this homonymous hemianopia, visual agnosia, prosopagnosia, alexia without agraphia, memory impairment and thalamic pain syndrome. So when thalamic branches are involved. So what happens in posterior cerebral artery? You have to remember this: homonymous hemianopia, visual agnosia, alexia without agraphia, memory impairment and also thalamic pain syndrome when thalamic branches are involved. Then coming to the internal capsule stroke. So in the internal capsule stroke, the internal capsule, it contains densely packed corticospinal and corticobulbar fibers. So what happens in the internal capsule? The corticospinal and corticobulbar fibers are densely packed. So most infarcts are lacunar strokes due to lipohyalinosis or microatheroma affecting the small penetrating arteries. So why the infarcts in lacunar stroke are mostly due to why does they occur? Because of lipohyalinosis or microatheroma affecting the small penetrating arteries. So what are the major risk factors? Hypertension, diabetes mellitus, aging and smoking. The risk factors are hypertension, diabetes mellitus, aging and smoking. The posterior limb. See, the posterior limb of the internal capsule, it's supplied mainly by the lenticulostriate arteries and the anterior choroidal artery. Okay, so the posterior limb of the internal capsule, it is supplied mainly by the lenticulostriate arteries of the middle cerebral artery and anterior choroidal artery. So what is the hallmark syndrome? It is pure motor hemiparesis affecting the face, arm and leg. It is a pure motor hemiparesis affecting the face, arm and leg. So pure lacunar infarcts characteristically lack the cortical signs. So here what will happen? The cortical signs will be absent. So there is no aphasia, neglect, visual field defect, apraxia, agnosia, seizures, cortical sensory loss. All these are uncommon with internal capsule stroke. So what are the other lacunar syndromes? The other lacunar syndromes include pure sensory stroke, okay, sensory motor stroke, ataxic hemiparesis and dysarthria, clumsy hand syndrome. So what are the other lacunar syndromes? What are the other small vessel disease? So pure motor stroke, it is due to internal capsule, posterior limb. Pure sensory stroke, it is due to thalamus or internal capsule. Sensory motor stroke means it's a larger lacuna involving both motor and sensory pathways. Ataxic hemiparesis, so it occurs due to small vessel disease in the pons. Dysarthria clumsy hand syndrome, again it is in the pons, basis pontus. Ataxic hemiparesis, it is in the cerebellar peduncle. Dysarthria clumsy hand syndrome, basis pontus. Pure dysarthria pons. Cognitive or executive dysfunction occurs because of the small vessel disease occurring in the frontal subcortical circuits. So imaging correlation. So CT may initially be normal. MRI diffusion weighted imaging is the most sensitive modality for acute ischemic stroke. What is the sensitive modality for acute ischemic stroke? It is the MRI. Cortical infarcts follow a vascular territory and involve the cerebral cortex. Lacunar infarcts are small, less than 15 mm. So what happens to the lacunar infarcts? They are small, less than 15 mm. So these are the deep lesions involving the internal capsule, basal ganglia, thalamus or pons. Lacunar infarcts, internal capsule, basal ganglia, thalamus or pons. So what is the take home message? Hemiplegia plus cortical signs, that is hemiplegia is there and cortical signs are there. So aphasia, neglect, hemianopia, apraxia, cortical sensory loss or seizures, they strongly suggest a cortical stroke due to large vessel disease. And pure motor hemiplegia without cortical signs suggest an internal capsule lacunar infarct due to small vessel disease. So clinical localization should always precede radiological localization. So what are the Harrison's clinical pearls? Cortical signs localize the lesion to the cerebral cortex. So if cortical signs are there, so it will localize the lesion to the cerebral cortex. So pure motor hemiparesis is the classic lacunar syndrome due to posterior limb internal capsule infarction. So only motor hemiparesis is there. So this will localize to posterior limb of the internal capsule. So absence of aphasia or neglect does not completely exclude cortical stroke, but their presence strongly favors a cortical lesion. So though aphasia is absent, neglect is absent, but it does not completely exclude, but if it is present, it strongly favors a cortical lesion. And MRI diffuse weighted imaging, it's the most sensitive imaging for acute ischemic stroke. And clinical localization should always precede radiological localization. So here in the cortical stroke, what should be there? Weakness and cortical signs are there. In an internal capsule stroke, it is pure contralateral motor plus or minus sensory. Higher cortical functions are affected in cortical stroke. Aphasia, neglect, homonymous hemianopia will be there. And seizures are uncommon. Etiology is a large artery disease or cardioembolism. So internal capsule, it is due to small vessel disease because of hypertension and diabetes mellitus. Lesion size is large or territorial. Here it is small lesions. Prognosis variable depends on size and location. Generally better, but in lacunar stroke may have persistent deficit. Okay.